Welcome to Grand Rounds. It's my pleasure to introduce Dr. Damon Scales to present at Grand Rounds this morning. Dr. Scales is an associate professor of medicine in the Division of Critical Care Medicine at the University of Toronto. He completed medical school, residency, and fellowship in adult critical care medicine at the University of Toronto, and also received his PhD in clinical epidemiology at the University of Toronto. He has previously served as the program director of the Adult Critical Care Medicine residency program at the University of Toronto, and is currently a faculty member of the Institute of Health Policy at the University of Toronto. He has received numerous awards related to his research achievements, as well as multiple teaching awards. He has been the investigator on numerous critical care studies, ranging from management of pain in the ICU setting, to timing of extubation in neurologically impaired patients, to pre-hospital treatment of sepsis by paramedics. And he has also authored numerous peer-reviewed articles relating to improving post-cardiac arrest care and prognostication of neurological outcomes. Today, Dr. Scales is presenting on moving critical care upstream, studying time-sensitive treatments. Please join me in welcoming Dr. Scales.
Great. Thank you very much for the introduction, Andrew, and thank you for the invitation. It's terrific to be here. You'll see as I give my talk that in many ways I feel like I'm bringing coals to Newcastle, because a lot of the work I'm going to talk about has been conducted by a lot of the research that I'm talking about has been conducted here in Seattle, actually. I hope to convince you at the end of this talk that we need to work harder to break down the silos of care that characterize our medical system, chiefly to bring treatments that we know are time sensitive to patients where they are when they need it. And I'll finish the talk by discussing some of the research we're doing in this area. The disclosures that I have are just relate to my operating grant funding, 2 different grants to study time-sensitive therapies. My talk has 3 sections. I'm going to start by framing the concept, and maybe this will seem intuitive, that time-sensitive treatments should be given more early, but I want to talk to you about how we might do that better. I'm going to focus on 2 examples, cardiac arrest survivors, earlier treatment, and patients with sepsis, and this relates specifically to research programs that we've developed in Toronto. I should say, this is a new talk for me. I'm trialing it on you first, but it's the one that I'm most excited about because it focuses on what we're spending our time on now. And I'm going to just commiserate really at the end about a lot of the pragmatic challenges that we face when trying to conduct this type of research that isn't conducted in the controlled environment of our hospitals, which might not seem so controlled, but it can be worse, I'll tell you. So this is the main message. I think prompt pre-hospital treatment can improve outcomes of patients when they are critically ill, early recognition, early identification, perhaps early transport, or early therapy. Start with several examples. Of course, you always start with examples from cardiology because they always do things right before we do, but this should be a no-brainer. If someone has an acute MI, you want them to get to a treatment center as promptly as possible. This is a nice publication that characterized where delays often happen between the onset of symptoms in someone who's presenting with an acute myocardial infarction to when they actually get treatment, primary PCI. And what they've highlighted here is that there often is a delay in the assessment at the scene, transport to hospital, that we often feel is beyond our control. In the hospital, we can do many things to try to expedite care, bring someone straight to the cath lab right away, but these things that happen before the hospital are often harder for us to control. And it's even worse, of course, if the patient is first brought to a center that doesn't have PCI, because then you have to actually move the patient to another hospital that has appropriate facilities. As I said, this is the straightforward example. But what I like about this paper is they show that these delays do translate into meaningful changes in patient outcomes with a much higher mortality rate amongst patients who experience the greatest delays from symptom onset to symptom recognition and treatment in the pre-hospital setting to appropriate triage and transfer to a hospital. Many investigators have talked about trying to treat this specific condition earlier than the hospital. This is an older systematic review conducted by one of my colleagues in Toronto, Laurie Morrison, but showing that there certainly is a signal, if you're brave enough to do this, to giving thrombolytics in the field, that this therapy can lower outcomes. I can tell you we don't do this in Toronto, and I think that's largely because the focus has really shifted towards transporting these patients as quickly as possible to PCI centers. And that's what this study shows. If you're transported directly to a PCI center, then you have much better outcomes than if you're transferred to a center that doesn't have primary PCI and you have to be subsequently moved again, or you receive primary thrombolysis at the destination hospital. This study was published in the New England. This comes from Canada, but it represents the results of work to basically create a STEMI bypass protocol across the entire region. And I think these are common everywhere now, but showing that these systems where we empower pre-hospital providers to identify and recognize acute conditions and transport them can have meaningful impacts on our patient outcomes. Another example, and again, lots of work from this region in this area, but acute trauma, I think we all take this for granted. I don't want someone who's got a multi-system trauma going to a center that can't handle multi-system trauma, and so our pre-hospital providers are already trained to recognize and appropriately triage patients who have this condition to other places. Can therapy be given earlier? Well, I just want to again give a shout out to local research. So we know that TXA is a time-sensitive therapy given to patients with trauma and improves outcome through its mechanism of decreasing bleeding. And this is an ongoing trial conducted by the ROC network, led here in Seattle, to try to test whether or not earlier administration of TXA by paramedics in the field can translate into better outcomes. So watch this space. I know that I'm meeting many people from the pulmonary critical care world today. Can acute respiratory failure be something that can be treated earlier before we see these patients in the emergency department? Well, there's actually I think a pretty compelling evidence base that if your system is equipped to treat these patients earlier, more upstream, you can prevent a lot of badness downstream. So in this particular study conducted in France, they showed that when they provided CPAP for what the paramedics diagnosed as acute pulmonary edema, improvement in their primary outcome, which was a composite endpoint including respiratory failure, intubation, death, etc., but also fewer intubations, which I think is a very practical endpoint. When combining this study, which was the largest, with all of the other randomized trials in this area, I think there is a pretty compelling signal that if you treat people with acute respiratory failure with CPAP or BiPAP, that you may prevent many of these patients from requiring intubation and mechanical ventilation. So that was my section on framing the issue with other examples. I think we could probably come up with a longer list than this of other therapies that we treat all the time in our clinics, in our hospitals, in our emergency departments, where we feel frustration that treatment could have been provided earlier, and where there may be advantages to trying to move therapy further upstream. I'm going to focus on these two examples because that's where our research program has taken us, in particular, how we might improve outcomes for patients who've been resuscitated from a cardiac arrest, and patients who have acute onset or the initial identification of sepsis from any of these potential sources. Starting with the cardiac arrest example, I like this example because, of course, a cardiac arrest can be a devastating event. Fairly consistently across studies, outcomes of survival after someone's experienced an out-of-hospital cardiac arrest ranges about 8%. I happen to be speaking to a very fortunate audience because you have some of the highest survival rates in the world when it comes to out-of-hospital cardiac arrest, because you have some of the highest bystander CPR rates in the world. It's certainly not that way where I live. We, of course, see the survivors. So after someone's been resuscitated out of hospital and they're transported to one of our emergency departments, we've seen a group that's selected because they've had a return of spontaneous circulation. They're alive, not dead. So survival rates in that group is much higher, and again, fairly consistently, about 40 to 50% overall survival if someone has been resuscitated and is alive in the emergency department. We've been monitoring with a large registry that we've created that covers a population base of about 8 million people in Southern Ontario where I live. And we've seen improvements in our own local region. I'd like to say that this is because of the treatments that we give to these survivors when they're brought to the hospital, but I know better. It's largely because there's been a major focus to try to improve the pre-hospital resuscitation. Our paramedics are trained to provide CPR way better than I know my residents are trained to provide CPR, where they get routine reports and feedback about the quality of their CPR, and I think that really explains this trend we're seeing. But I would like to think that there are other therapies that we provide to these patients that might also improve their outcome. And certainly, this trend in improved survival does post-date, or it comes after the publication of some landmark trials that showed that earlier cooling after cardiac arrest may improve outcomes. These are the two landmark trials I was referring to, the Bernard trial and the Hackett trial. I'm not going to spend a lot of time on these, but just to say that proof of concept is pretty compelling from these two randomized trials, that if you cool a survivor of cardiac arrest, you can decrease secondary brain injury and improve rates of neurologic outcome. Taken together, these two trials showed a number needed to treat to have one more patient survive with good neurologic outcome of 5. I challenge you to think of other therapies that have a mortality or survival benefit with good outcome, with a number needed to treat this small. Of course, the alarm bells might be ringing there saying maybe this is too good to be true. I'm with you, but it's still, the signal is very impressive. And there's good biology from the basic science world showing why cooling after interruption of blood flow might change trajectory, decrease secondary brain injury, and perhaps in a time-sensitive manner, where you the earlier intervene to drop the metabolic rate, to drop oxygen consumption, you may decrease secondary damage. In the animal world, where you randomize mice who've been intentionally arrested to either getting cooled or maintained at normothermia, there's a clear survival advantage, and it seems to be time-sensitive, where if you initiate hypothermia and bring down the temperature of the organism early and promptly, more of these animals survive than delayed. In our region, after this work goes back about 8 years now, we determined that some hospitals were very quick to adopt this therapy, but many hospitals were very slow. You can see some summary statistics here that about half of patients who were deemed eligible for cooling were getting a cooling protocol implemented. And if we do believe that there's a time-sensitive benefit to providing cooling earlier, only a very small minority of patients were achieving the target temperature within this somewhat arbitrary threshold of 6 hours that we determined. We set out to try to improve this using a network of hospitals that we created, 32 hospitals in the Greater Toronto Area, covering a total population in this case of about 4 million people in terms of the population served, and implemented a quality improvement initiative, and this is very similar to many multi-center quality initiatives that have been published in other areas, where we have a central coordinating system that tries to quarterback the quality improvement initiatives across many hospitals, providing regular audit and feedback reports to every hospital with their performance rate, going in and giving them talks, going into the emergency department and finding out where they keep the fridge for the cold saline that you need to start the cooling, and kind of an iterative process. We evaluated this in a step-wedge cluster randomized trial. I'm not going to spend a lot of detail on the mechanics of this trial, but just focus on the results, which were disappointing. So in the quality improvement world, I'm congratulated by these results. Wow, you almost tripled the rates of your primary endpoint, which was cooling to within the target temperature in 6 hours. But I left this exercise feeling depressed, because at the end of it, only 30% of the patients were achieved our primary endpoint of being cooled to target within 6 hours. You can see that at the end of our intervention, which went over 3 years, and involved thousands of patients. We only had, in total of resuscitated patients, a smaller number of cooled patients, but 66 were ever cooled. And we did move the needle in terms of time to cooling, but again, in this case, not significantly, and I would say I'm not even sure how clinically important that hour difference is in time to target temperature. So we tried to come up with a better approach to decrease these delays, which we felt were mostly system delays. The time that it took for a patient to arrive in the emergency department, be seen by the appropriate people who are skilled and knowledgeable to implement cooling, to actually get someone to the ICU where this often happens. We felt that many of our challenges that we couldn't overcome were system delays. And so we designed a randomized trial focusing on having this therapy provided by a group of providers that we know are used to following protocols, that tend not to deviate from instructions, and who see these people much earlier than we see them in the emergency department. This was our ICEPACS RCT. The hypothesis here was that having a paramedic who's just finished resuscitating the patient and is invested in this patient's outcome, because they've just spent all this time resuscitating them, that if they implemented cooling right away in the field, that when the patient showed up in the emergency department with a bunch of ice packs and cold saline running, that we as in-hospital clinicians couldn't resist but continue the cooling process. That's where we were going with this. So a large undertaking. This is only the second time I've presented the results of this randomized trial. It has not been published yet, so no pictures, please. We again used the same network, and this was pragmatic because we already had the infrastructure in place. We targeted the usual people that would be targeted for therapeutic hypothermia, focusing on all rhythms, and perhaps that's not everyone would agree that we should cool all rhythms, but we did. And waiting for about 5 minutes after, for at least 5 minutes after a ROSC, because most rearrests happen within the first 5 minutes after successful resuscitation. And we wanted to delay the therapy until we were through that period where there was going to be a rearrest situation. This was our intervention. So we stocked every truck in the region with these coolers that we got from Canadian Tire, which is our version of Walmart. We filled all of these coolers with frozen saline, and the frozen saline bags were interspersed with saline that was kept cold for cold infusion, and every patient got one of these wristbands that said, "I've just survived a cardiac arrest, cooling's been started, please continue cooling me." The comparison group was usual resuscitation and transport, and everything, of course, that happened in hospital was left to the discretion of the receiving team. Our primary outcome was, again, this process measure that I still feel is meaningful, that the proportion of patients that were cooled to the target within 6 hours, and lots of secondary outcomes around safety and harm. The next slide is a lesson for young researchers who embark on a 4-year randomized trial. It's the point being, you never know what's going to happen when you start the randomized trial. This happened to us. Someone did what we're doing already, but better. Thank you. This was a really nice trial, much larger than our sample size, in the end, about twice as big. But the same question, slightly different mechanics in terms of the intervention, a very nicely conducted study by a very skilled EMS system, no difference in outcomes, clinical outcomes, in terms of rates of survival with good neurologic outcome, and concerningly, a trend towards harm in the patients who were cooled by the paramedics. In terms of rearrest rates, so more patients rearrested if they were cooled early, and higher rates of pulmonary edema diagnosed in the emergency department. So you can, this is 2.5 years into our trial, this is published, now what do we do? The other thing that happened, of course, is the publication of this trial, which is certainly the most rigorous of the in-hospital cooling trials to date. They didn't have a usual care control arm. Instead, they focused on controlled normothermia, so active cooling, but only to 36 degrees. But they didn't show any difference in clinical outcomes. And this, of course, was concerning to us because our primary outcome was getting cooled to 34 degrees, and we worried that with the publication of this trial that if we're doing all this work pre-hospital to get people, the cooling started earlier with our endpoint being cool them to less than 34, if the in-hospital clinicians are changing their practice to target only 36, we're going to have trouble with our endpoint. So all this happens in the middle of the trial. We have emergency meetings with DSMC, and fortunately they were very calm, much more calm than I was, and they suggested that we continue to our to conclude enrollment and made the point that we don't know how quickly people are going to change their practice. So In the end, we randomized 585 patients. There's a slight imbalance there. 275 received pre-hospital cooling and 306 received no cooling. And I'm 100% certain that the reason that we have that imbalance represents some randomization irregularities where the paramedic might not have liked what the patient was randomized to and the patient didn't get cooled. So I'm certain that's some of what happened here to cause the imbalance, but still a relatively symmetric distribution. No differences in our table 1, which I won't show you, but I will jump to the results. So our primary outcome was not significant. There was a trend there, but this was interesting. We did show an increase in rates of ever cooling in the hospital. And so my takeaway from this, and you have to find your spin, but I do feel that this hypothesis that pre-hospital cooling may have catalyzed in-hospital care may have some merit. And this may be one more example about how things we do before people get to the hospital may have an influence on what we do in hospital. So again, catalyzing behavior. No change in clinical outcomes. I'll just pause here because I can't help make this point when I present the cardiac arrest research that most people that survive to leave a hospital with cardiac arrest have a good outcome. And I think this is an underappreciated truth. You see here that the distribution of outcomes in our trial, there's a lot of people that don't survive, but of those that survive, most of them have what we'd consider to be a good functional outcome, which is reason to not be too pessimistic. We also looked at for a signal of harm here, and we didn't see the same trend that they saw in the Seattle trial. There was no difference in rates of rearrest, and in fact, if anything, there was lower rates of pulmonary edema in the pre-hospital cooled arm, and that could be spurious. It could also be that our cooling intervention our patients didn't receive as much of the cold fluid during their transport to hospital, and that may relate to transport times, it may relate to how the fluid was administered. The median fluid infused in Seattle was close to 1 liter, so a smaller volume. And other differences, and there's since been an Australian trial that has similar results to the Seattle trial. Both of these other trials started the cooling either during the arrest or immediately following the resuscitation. In our trial, as I said, we waited for 5 minutes to have a stable circulation. Maybe that's one of the reasons why we had a difference in harm. I don't know, hypothesis generating, but certainly not a compelling signal that pre-hospital cooling in this setting led to improved patient outcomes. So you find a different condition that's going to illustrate the concept that you want to highlight, and that's what we've done now. Focusing on whether or not earlier treatment of sepsis, again, moving the point of first contact and care delivery to outside of our hospital walls might improve outcomes. I know this audience knows about sepsis and what it entails. I just feel I need to put up the new definition thanks to the new consensus guidelines. Certainly, we're seeing more and more sepsis. This shouldn't be surprising because sepsis has an age-related incidence as our populations get older. I think we can anticipate we will see more cases of sepsis in our emergency departments and in our intensive care units. And of course, there's proof of concept already that earlier recognition and treatment of sepsis might be beneficial. This is the Rivers trial. Again, perhaps an implausibly large effect size, but demonstrating the concept or suggesting that earlier resuscitation using a goal-directed protocol could improve patient outcomes. Lots of concerns about this trial in terms of it being a single-center study. The usual care arm maybe wasn't the same kind of usual care that we would provide. I mean, I think we would all agree that just neglecting a patient isn't as good as providing them with any treatments. I'm not saying that's what they did here. I'm just saying that usual care should involve some treatments. And again, perhaps there's an implausibly large effect size. And of course, the Rivers trial has now been replicated in many countries. So 3 large international trials, all published in the last 2 years, all failing to show an improvement with a protocolized approach to resuscitation, similar to what they use in the Rivers study, to a less intense resuscitation protocol. I think the point I would make about all of these trials is that they are conducted in the modern era, where I think we've become much better at resuscitating and identifying our septic patients. I know that after Rivers was published, our hospital had a sepsis team implemented. There were sepsis quality improvement programs targeting the emergency department. Let's recognize and treat these people early. So I think things are very different, and I think that the comparison between the previous era, when the Rivers study was conducted, and the modern era, if that's what we're going to call today, is challenging. And I'll make the point that at the time that these patients were randomized in this particular trial, the PROCESS trial, the average fluid that the patients had received was 2 liters. So they'd already received a large fluid bolus for resuscitation, and I'm not sure that says that early resuscitation isn't helpful because, as I said, these patients were already early resuscitated, and that's the point I wanted to make here. So I still think that there is a question to ask about whether even earlier, my voice is getting louder. Or is it in my head? I think there is an argument to be made that the most recent large randomized trials haven't addressed the question or answered the question about whether even earlier resuscitation of patients who are critically ill with sepsis might be beneficial. This might seem obvious. Of course, if you have an infection, you should get earlier antibiotics, but I think this is a great opportunity to study whether even earlier antibiotics, given appropriately, and that's maybe the key, will be helpful or not. Lots of great animal research to support this. If you take a mouse model of sepsis, either cecal ligation or the various other, sorry, Conrad, and the other models they have here, there's a striking difference in terms of survival rates, so much, in fact, that if you give antibiotics at the time that you implant a disc of bacteria in one of these sick animals, survival rates are the same as the sham model, who doesn't receive any septic insult. So prompt antibiotics given at the time of injury certainly has a dramatic impact on survival. And of course, there are human data. This is from a publication that comes from a large Canadian sepsis registry. Anand Kumar is the lead author. He's in Winnipeg. And he looked at a data set that included adjudicated sepsis cases. So to get into this study, you had to have chart review by 2 different assessors adjudicating you truly do have sepsis, and then looking at your outcomes depending on how long the delay was from the onset of hypotension to the first dose of antibiotics. If you got antibiotics within 1 hour, you had 80% survival, patients, real people. Each hour of delay decreased absolute survival by 8%, so that within half an hour, survival was 83%. If your delay to antibiotics was 6 hours, survival dropped to 42%. The median time to antibiotics, this is a real-world study reflecting on our real Canadian practice, was 6 hours after the time of hypotension. To graph their results, they had to use a logarithmic scale because the signal was so strong. Again, not a randomized trial. We don't know why the delays were happening in all these cases. That may be a major important confounder. I'll point out that a patient that doesn't get antibiotics for 30 hours or more, something's going on there that's different than the patient who gets antibiotics promptly and they need it. It's either really bad clinical care, or perhaps a confounding clinical situation where the diagnosis of sepsis isn't readily apparent, and I don't know that the extremes for certain are that comparable. We do know that delays to antibiotics are common, so credit to Chris Seymour, who's got another active research program in this area. This is a work in press looking at the Pennsylvania EMS system. Again, community-acquired sepsis transported by EMS, in-hospital mortality of 11%, but the median time from first contact by the paramedic to the first dose of antibiotics was 4 hours. The median pre-hospital day was half an hour, and the median emergency department delay was 3.6 hours. So this is another slide from Chris Seymour. I like it because it nicely illustrates the concept I'm trying to promote here, that perhaps we can decrease some of these delays in time to appropriate therapy by moving beyond our silo of working in the hospital. Certainly, sepsis is encountered commonly by EMS. Another great study here that shows that the sepsis incidence is increasing, much more frequently encountered by EMS in these 2 other conditions that we seem to get so excited about, but a much higher mortality rate as well, a 20% in-hospital mortality rate for this cohort of EMS transported septic patients compared to around 10 to 12% for the stroke and MI patients that were transported. In some regions, the UK, for example, they've gotten on board this concept by trying to empower their paramedics to identify sepsis and call a code sepsis. No difference in treatment, but early identification to try to cue the receiving team that I think this patient has an infection, maybe you should treat them promptly and appropriately. We want to take this one step further, so this is research that we've been fully funded to conduct. It'll be a large, pragmatic, randomized trial conducted in our region. Our primary research question: does earlier identification and treatment by paramedics at the time of first contact improve survival? It's a 2x2 factorial. There'll be an antibiotic versus placebo arm and a liberal fluid resuscitation versus conservative fluid resuscitation. And we're very excited about this. Of course, there's lots of challenges. We're asking our paramedics to make a complicated diagnosis that I'd say is a big problem for us already in the hospital when we have blood work, radiology, microbiology. Getting the diagnosis of sepsis right is not easy. And we're asking in this trial whether or not a more limited assessment at the time of first contact can still lead to appropriate therapy and not an excess of inappropriate therapy in patients identified by sepsis. The available literature around the accuracy of paramedics for identifying patients who are subsequently determined to have sepsis is limited. This is a systematic review done by one of my students. I'll say that almost all of these studies focused on the SIRS criteria, which have now fallen out of fashion, but basically abnormal vital signs and a suspicion of infection. And you'll see that the sensitivity is not great, but the specificity is probably not terrible, which I think is most important. I'm less worried about missing an occasional patient with sepsis in our study, but I want to make sure that if the paramedics are treating a patient like they have sepsis, that there's a high likelihood that they really do have an underlying infection. I've alluded to these already, the new Sepsis 3 consensus definitions. They have recommendations about how we might do this better, how we might identify patients with infections more appropriately. This is what they recommend for my world, the SOFA. Trying to get a paramedic to do this, of course, would not be feasible. They don't have access to many of these elements. It's just too complicated. But their recommendation was to use what's called this quick SOFA. And if you have 2 of 3 of these vital sign abnormalities, and that's really what these are, they're just basic vital signs, 2 of 3 of these vital sign abnormalities in the context of suspected infection, you identify a patient population with infection that have a higher risk of mortality. The consensus, the Sepsis 3 definitions don't give a lot of advice about how to actually refine our identification of infection in the first place. It's mostly they're mostly focused on identifying a group of patients who you think has an infection, who then has a higher risk of dying. We looked at this, we thought about this in our design phase, and we weren't really thrilled about the first 2 in particular because we felt them to be more subjective. I can tell you that everyone in my ICU has a rest rate of 20 unless they're really sick. I think that's just what gets charted, so I'm not sure how well we assess that routinely. And ultramentation is also subjective. So we wanted to focus just on hypotension. Chris Seymour, who's one of our collaborators and a co-investigator on our grant, had some nice work that he was able to generate to show that if we just restricted to the criterion of hypotension, we identified a cohort of patients with infection who had a similar risk of dying than a cohort that had the 2 of the 3 QSOFA. And so that's what we've gone for. Paramedics suspects a possible infection. We've had a large CME program targeting the paramedics to try to improve their understanding of how sepsis can present. All of our patients have to have a fever. Those are Canadian units there, 38 degrees. But this is, I think, very important because of all of the things we have in the field, this is probably going to improve our specificity the most. There's other reasons you can have a fever, but without a fever, I think it's becomes much less likely that you have an infection. And they have to be sick enough to warrant this pre-hospital intervention, so they have to be hypotensive. This will be our 2x2 factorial, so placebo versus ceftriaxone given intramuscular, and at the same time there's a randomization to the usual approach to resuscitation, which in our world is only giving fluids if your systolic is less than 90 and stopping if it's higher than that, versus giving 2 liters to everybody who's into the trial. We spent a lot of time discussing this. I'm not sure that ceftriaxone would be the first drug of, I don't know your profiles here. I can tell you that in our region, this is still the workhorse for us. It's still what we use first line for all of the common community-acquired infections. It's one that we have a lot of experience with. There's a large literature to talk about the safety already, broad spectrum, and we have low rates of resistance in my neighborhood anyway. And perhaps one of the most appealing things about this particular antibiotic is that you can give it IM or IV. And there's lots of reasons why for a pre-hospital intervention, IM is so much more appealing. Number one, the minute you give it, the drug is working. So the patient's randomized, they get an IM injection, and that's your time to antibiotic, as opposed to fussing with setting up an infusion that, if you read the monograph, should be infused over 20 minutes, which happens to be most of our transport times. It becomes complicated. Not all of our paramedics are trained to insert IV, but they're all trained to insert IM, so that's another appealing advantage. And when you look at the pharmacokinetics, and this is a slide from healthy volunteers, but you get very similar drug levels, at least within about half an hour of administration, as you would if you gave it IV. And the pharmacokinetic profile is such that the drug is above the MIC for the whole 24-hour period. That's the approach we're going to go with. This is the other issue we've had to navigate, and I will concede that I think that when it comes to measuring the safety of this intervention, this will be the big issue. Our paramedics we've determined it's not feasible for them to collect a blood culture sample out there in the field and then bring that sample to our emergency nurses and say, hey, can you run this to your micro lab? We have about 32 destination hospitals. They don't all have the same microbiology processing infrastructure. There's paramedics who've been in our system for a while who remember a day when they used to collect blood and they'd see the bag of blood be disposed of the minute they dropped the patient off, and I think that's a truth. So we decided we were not going to get blood cultures for pragmatic reasons. This is a deviation from what's strongly recommended in the surviving sepsis guidelines. These are I noticed in my email today the 2016 guidelines that have just been published. But the strong recommendation, grade 1C, which means strong recommendation, C means low level of evidence, that you should try to get cultures where possible. But they also make the point that if you think the delay is more than 45 minutes, that this should not delay your administration of antibiotics. And this has been our argument. We know from our pilot work that the delay is always more than 45 minutes. So we're still in keeping with the guidelines. But this will be something I think very important to track when you're rolling out a study like this. And I'd argue the reason you need a randomized trial of an intervention like this, rather than just saying, hey, that's a good idea, we should implement it. I think there are potential harms. Our primary outcome will be mortality at hospital discharge. Secondary outcomes, all of these endpoints to determine whether or not earlier recognition and treatment can change the trajectory and prevent some of these patients who might otherwise end up in my ICU from actually coming there. And then really important, these safety outcomes. We're giving a lot of fluid in the field, so looking at rates of pulmonary edema. We're getting microbiology on everybody. They'll have had a dose of antibiotics already, so admittedly there may be lower positive culture rates in patients who've had the antibiotic, although I've learned from my ID and micro collaborators that most modern blood culture systems have resins that precipitate antibiotics to help increase the yield, but something we'll want to watch, rates of culture positivity in both groups. Importantly, how often did the inpatient clinicians agree with the paramedics that this really was an infection and not pancreatitis, for example. So we're supposed to launch this month, actually. We've been a bit delayed, and I'm going to talk about reasons why we've been delayed, but we're still hoping for March. As I said, we've secured the funding. I've trained over 15, I haven't, but we've trained over 1,500 paramedics on how to deliver the intervention. Where we're stuck right now, as I'll get to, is the many regulatory issues that need to be overcome. But I do believe that there's a potential here to impact on clinical outcomes, and I've already argued why I think it needs to be tested in a randomized control trial. Challenges. The first thing I would say is you never can predict where the challenges will come. Our biggest hurdles always in getting one of these trials up and running relates to the practical issues of having an intervention delivered in the field and having all of your outcomes measured in the hospital. Because it means you need to go to different places to get approval for different processes. All of our EMS in Toronto, we have 4 large EMS, and so they happen to be covered by 2 research ethics boards. That part ended up being pretty straightforward. I mean, there was a lot of back and forth about safety and refining our protocol, but getting approval for the pre-hospital intervention has proven to be much easier than getting sign-off from all of the receiving hospitals that we can get in and access patient data. Especially, and I'll come to this, with our consent model. So this is, just as an example, our pre-hospital cooling trial. These were all the destination hospitals, same issue. They all had to sign off on the protocol. They all had safety concerns we had to address. Every IRB, even if you say, I'm only coming in to do chart review, they still want to talk about the safety of your protocol. They still want to look at your notification or consent letter. I'm not sure how the system is set up here, but I can tell you that this regulatory issue has been a major challenge for us, and I think a strong argument for having more centralized oversight of research. Not to say we don't need IRB oversight, but having 22 different reviews is challenging. This is another real problem. Paramedics are generally not trained to assess for capacity and to obtain informed consent. And this is an issue we had to think about really carefully. I think when you've just resuscitated someone who's had a cardiac arrest and they're all in a coma, your justification for a waiver of consent is much stronger than if you're talking about how to approach research consent in a patient population who's very sick. They're all hypotensive, they all have infection, but they're not all in a coma necessarily. And looking at those in-hospital trials, almost half were able to give first-person consent because they still were capable. So this was, I'd say, we've been funded for over a year, and this issue is one of the ones that we've worked, I think has taken up much of our time to try to get right, working with our IRBs to make sure they're happy, to make sure that the patient who is capable has an opportunity to decline participation. This is a nice review article that was recently published that tackles or suggests, I think, the 3 most commonly suggested approaches to getting consent for research in the pre-hospital setting. There's a simple opt-out. That's what we're going to use. I'll show you our script. Informed refusal, where it's an abbreviated consent process, and then you ask a question. Do you agree to continue? Or just actually the way we do informed consent in hospital, but perhaps a bit abbreviated, more targeted. We're giving this script. It's a very short summary of the study, written in a fashion that the paramedics can actually read to the patient or their relative at the bedside, and they're instructed that if there's any objection, don't proceed in the trial. And the script is such that if it invites the patient, if they have any objections to receiving or proceeding in the research, that we'll just give them the usual treatment that we would always do. I'm not sure if this is the optimal approach. It certainly is one that's, I think, working better for us than trying to have all of our paramedics go and seek informed consent and assess capacity. But you can appreciate there's certainly challenges here. And just finally, I'll just conclude saying that as someone who grew up in the in-hospital research environment, this has been a major eye-opener. With our cooling trial, we launched, and then I immediately got a letter saying that one of our large EMS would not participate because they were in a dispute with management. And research is, as it always needs to be, a voluntary exercise, and if you're an essential service and you want to make a point, you stop doing your voluntary work, which includes research. The trial kind of got shut down for about 5 months. We had trouble with, so we wanted to use fridges in the station to keep our saline cold between shifts, but then we had a complaint that then there was no place for the paramedics to store their lunches, so we had to buy new fridges for all of the unions. I lost about 25% of the coolers that we supplied in the summer months, and I know where they ended up. Shortly after we launched, it was identified that we hadn't gone through the appropriate process of making sure the cooler could be appropriately secured in the moving truck and wouldn't fly away and hit someone, and that's legitimate, and I honestly just didn't see that coming at all. And wear and tear. So again, the cooling example, we started out the trial with frozen saline bags, which I thought was ingenious, putting frozen saline bags in the cooler. They're cheap. A bag of saline doesn't cost hardly anything. But it turns out if you freeze and thaw them, you get a big puddle. The bags break very quickly. So about 6 months in, we had to buy a whole bunch of custom-made cold packs that are meant to be, the kind you'd use on your sore elbow. They also don't last for more than about 6 months, and instead of getting a puddle of saline, you get a puddle of blue goo that nobody wants to work with. So these are the things that I think they just don't teach you in research school. The latest issue we're navigating, so ceftriaxone, and I apologize because I know the Celsius range, but the recommendations that are approved in our country are to store the powder, so the paramedics can reconstitute the drug, but we have to store the powder between 15 and 30 degrees Celsius. This is no problem in the hospital. That's room temperature. I can't do the conversion to Fahrenheit, I apologize, I'm embarrassed. But it's that's where we normally do 15 to 30 degrees. But in the winter, I can tell you that the trucks every day drop down below 15 degrees. And so I currently have a whole bunch of sample kits that have all been returned because the temperature monitor we've put on all of them has identified a breach within the first use. So these are things that you don't anticipate when you're rolling one of these trials, but it makes it fun. There's always another challenge, and hopefully you overcome it. I'm going to end there. So to conclude, I do think there are often important system barriers that can delay the delivery of interventions that I think we would all agree should be time sensitive. And I think there's an opportunity to think beyond our silos. Having our colleagues who are also very well trained identify and start some of these treatments earlier. And I do think there's an obligation to study considering the potential for harm. So I can give a real good pitch, I think, about why pre-hospital sepsis treatment might be better, but I think there are appropriate concerns about the identification of sepsis and the dangers of giving antibiotics to someone who doesn't really have an infection or who has resistant organisms. So I'll stop there and take questions. Thank you.
That was a great talk, and I maybe your next trial should be early blue versus Molson therapy. Just a comment I would say is we actually did sort of a uncontrolled trial of early antibiotics for pneumonia in this country when we had a federally mandated performance metric that said that you had to receive antibiotics within the first 4 hours of it coming to an emergency room, and subsequently shown that the rate of inappropriate antibiotic use went up dramatically, and the government, for that reason, withdrew that performance metric. So, I think your comments about making sure that it's appropriate antibiotics is really key, but the risk, I think, is there.
Thank you. Thank you.
50 years ago, when I was in medical school, I participated in a study by Jackson and McCabe showing the value that if you use the right antibiotic rather than the wrong antibiotic, the outcome is better. Sepsis. Not surprising. And their studies were all with gram-negative organisms. And the only thing we're lacking in this particular study is that to know that in sepsis now, in immunocompromised patients, many of them actually have Pseudomonas aeruginosa.
Sure.
Using ceftriaxone specifically doesn't cover that one organism. So the lack of using an organism which has been previously shown that if you don't use the right antibiotic, you don't have a good outcome. So I think, in fact, if you look back at the studies by McCabe and Jackson, what they showed at that time in gram-negative sepsis, if you use the right antibiotic rather than the wrong antibiotic, the patient's survival was better. Now, this is study that was done over 50 years ago. So I think that you will miss a lot of patients here that may indeed have sepsis by limiting your spectrum of ceftriaxone.
Yeah, it's a terrific point. I think it again highlights why you can't just roll something like this out. I think we're obligated to study it. I can say that, so we have thought about this concern, and I think, I'm going to say again, we have to measure it as a marker of harm, how often patients are subsequently identified to have resistant organisms because they were immunocompromised, for example. We talked about trying to exclude patients who had immunocompromise, but again, that's pretty hard to ask a paramedic to identify so just pragmatic challenging. We also talked about broadening our spectrum, and so using something like pip/tazo, for example. I guess one of the challenges that, so if we show a marked survival benefit, this will be a problem for the world to deal with when other regions have different microbiology resistant profiles than we do, for example, in my community. So we definitely have rates of MRSA, or there's an incidence of MRSA community-acquired infections and Pseudomonas community-acquired infections, but they're quite low. So our pilot work involving emergency departments in the region show that, in fact, less than 5% of patients who are brought by EMS to hospital are subsequently found to have a resistant organism. That there's a range around that depending on which hospital. Not to say those patients don't exist, but it's a minority. I guess what our hope is that when they're at hospital, and with the benefit of more investigative, more testing, et cetera, that a more appropriate antibiotic can be delivered. The clinicians won't know whether the patient had an antibiotic or not. They'll have a sheet that says the patient's been randomized in the trial. They may have had a gram of ceftriaxone. Our information sheet for clinicians says, if you think the patient has an infection, please proceed as you always would, including giving another dose of ceftriaxone if you think appropriate. I appreciate and I respect the concern, and I think it's the reason we need to study this.
Your outcomes for cooling with cardiac arrest. I didn't hear the role of other applications like CPR, anticoagulation, immediate contact with central stations, and all the extras that come around to cardiac arrest, whether they influenced your outcomes.
Yeah, it's another terrific point that there's many things that we know in a cardiac arrest survivor that can influence whether or not that patient lives or dies. We just randomized the pre-hospital cooling or not. The patients had already been resuscitated, but I think the point that focusing on good CPR is still needs to be the priority in the pre-hospital setting. If you ask me what I think the most important determinant of survival for a cardiac arrest survivor in hospital, so someone who's transported to our hospitals and is treated by us, I actually think far more important than cooling is avoiding unwarranted pessimism and stopping life support too early in patients who we've successfully resuscitated simply because they have an early neurologic examination that isn't favorable. So there's lots of things I think that are important for outcome. This last point is the focus of my third talk today, so it's just kind of a pitch for later.
If earlier may be better, I wonder if you've run across opportunities for triggering EMS system earlier, and then there may be signal outside the hospital that we now have ability to track that might augment what an individual might do in triggering it. And in the hospital, the same thing is true. So, for example, Eric Horvitz at Microsoft did an interesting study that looked at behavior of people in searching for information about their symptoms, and that turned out to be an interesting potential use of that signal to identify people with pancreatic cancer. But also in the hospital, people have behaviors that precede the clinician's recognition of sepsis that might be useful in pushing back the time that the system is triggered.
So if I understand the question, it's thinking about the opportunities for triggering the paramedics that the patient might have an infection. I love it. I think it's a great suggestion. I mean, we've focused on the traditional method of education, We've got a whole CME session now for every paramedic before they can enroll a patient, where they have to have been not just taught about the study procedures, but also had kind of a refresher about how to identify infection. But you're talking about even prompts, and I love it. Yeah. I love it as a next step or a good idea.
Damon, thank you. It was a great talk. I just wanted to ask a question. So you had a lovely series of sentinel papers that were subsequently disproven, another sentinel paper subsequently disproven, another sentinel paper subsequently disproven. And yet in the context of overall delivery and overall mortality in the ICU and critical illness in general, we've experienced a 40% reduction in mortality over time. So what accounts for that reduction in mortality, or what do you think reflects or accounts for that reduction in mortality when we have therapies that we are testing and then thinking that they're effective, and then turns out they're maybe not effective? So I just want to hear your thoughts about that.
Yeah, of course I have the answer, David. Yeah.
Of course you do. I was expecting that.
No, it's hard not to be a bit nihilistic these days with the onslaught of critical trials that have been indeterminate or not positive. But yes, you're right. The nice observational work showing that over time, despite not having more effective therapies, we're getting better at what we do. Maybe it's earlier recognition and identification. I mean, I do think that the Rivers trial was more a test of early recognition and awareness than actually the protocol for resuscitation. That's my own opinion. But maybe as when there's an intensive insulin trial that's published, maybe we get better at recognizing that someone should have their sugar controlled, and it's less important about how tightly it should be controlled, just that it should be looked at all. And maybe that's it. Lung protective ventilation. Maybe that's just caused us to focus more on other things about these patients with ARDS that they all should be getting. Because I've spent too much time thinking about cardiac arrest in the last few years, I'll come back to the same example I alluded to. I think that one of the major concerns about the early cooling trials is that when you're randomized to getting cooling for 24 hours, that prevents the clinicians from recommending the life support be stopped for 24 hours. And I think as we focus on these patients more, because we have something to do with them, we spend more time thinking about other things that they should be receiving. So that's my hypothesis.
Sorry, I just wanted to comment. There's also an effect of increasing diagnosis of sepsis for milder patients. So a lot of this is probably a denominator effect as opposed to a treatment effect.
Terrific point. Yeah.
All right. Well, thank you very much.
Thank you.